Whenever you guys are ready, please start. Okay, we're starting.
So our patient is 82-year-old Mrs. Whitney, who lives in West Parley, Ferndown. She's a regular attendant to the GP surgery and is seen by the practice nurses on a regular basis for her leg dressings. She has a past medical history of essential hypertension, a history of a vertebral fracture, osteoarthritis of the hip, osteoporosis, gout, hyperparathyroidism, a cerebral parenchymal hemorrhage, papillary carcinoma, and COPD. She lives with her husband with no package of care in place, but there's local support from their daughter who does all the shopping and takes them to appointments. The patient's husband assists with all the ADLs, but the patient is mainly independent with her wheelchair frame. The patient has regular blood tests to help manage and treat her comorbidities. Over the last few months, the patient started to slowly decline in her mobilities and in having tests which are looking into a possible cognitive impairment. The patient has also had a decline in her renal function in the last 6 months, with her EGFR going from 64 to 44, indicating CKD stage 3.
So we are going to have a look at the urinary system. It's the main excretory system and consists of the following structures. We've got 2 kidneys, which then go down to the ureters on each side. We've got the bladder and then the urethra. This is a female, so it's much shorter. Males, we slightly longer. Through this system, you have the formation of urine, maintaining water, electrolyte and acid-base balance. We have the excretion of waste products, the urine and other wastes, production and secretion of erythropoietin, which is a hormone that stimulates formation of red blood cells, and the production and secretion of renin, which is an important enzyme in the long-term control of blood pressure. The kidneys lie on either side of the vertebral column, so the vertebral column will be here, and there are 3 distinguishable areas when looking at the tissue. So I'm just going to so this is the kidneys sort of a lot closer, and these are artery places.
You can press on them.
Oh, there you go. That is your aorta and the vena cava, inferior vena cava. And then we look at a cross section of the kidneys. Sorry, no one see. So there's 3 main sort of structures when you're sort of looking at this. You have the outer fibrous capsule, which is around here. Don't know if it will. Okay, the capsule. Then have the cortex, which is that bit. And then you have the medulla, which is the pyramids in the middle. There we go, the renal medulla. Each pyramid has a point, so each of the medulla, each pyramid has a pointed end called the papilla. Urine formed within the kidney passes through the papilla and out through the drainage system, which begins at the minor calyx, which I think is, quite sure I did get it earlier, but
It's that little white bit.
this, yeah,
Just behind it.
you turn it.
That's a good idea.
It's somewhere. I can't get it to do it. So it goes through the minor calyx, which then goes into the major calyx, and then down through the renal pelvis, which is here somewhere because I pointed at that earlier. Oh,
It's a bit.
I don't know, somewhere here. And then it comes out through the urethra. The kidney contains 1 to 2 million functional units called the nephrons or the nephrons. So they're all within these parts. And the nephron looks like this. So you start with the glomerulus. Oh, I got all the really difficult words, which then goes to the glomerular capsule. Then we go down and through the proximal convoluted tubule, down to the medullary loop, which is also called the loop pendi, and along to the distal convoluted tubule and collecting down. which then goes down through the other bit. Filtration takes place within this bit, and filtration, because there's a difference in blood pressure between the glomerulus and the glomerular capsule. Filtration then forms filtrate, and usually you'd have a normal glomerular filtration rate is around 125 milliliters per minute. So the glomerular filtration rate is your GFR, which is what we found in Our Lady is producing. Usually that would be about 180 litres of filtrate formed by the kidneys each day, but nearly all of this is reabsorbed into the kidney tubules with less than 1 to 1.5 litres excreted as urine.
So we're talking about the abnormal pathophysiology. So the blood results suggest renal failure due to the GFR decreasing and the potassium level at 4.6 millimoles, with the normal range being between 35 and 35. And urea being 8.6, and the normal range for that is 2.5 and 6.7, and the sodium levels being slightly raised at 35 and 135. In a healthy kidney function, these levels would be in range, but with renal function failure, these start to deplete over time, and so the blood results start to rise. Urea and creatine are not particularly harmful to the body. However, the build-up over time is a marker for that harmful waste it's not being filtered through the kidneys. And in chronic kidney failure, the kidneys fail to remove waste products and remove excess water from the body, resulting in edema to lower limbs. Also, the blood pressure, kidneys have controlled blood pressure. So this is a case of our patient's got hypertension, which is high blood pressure. Some of the early symptoms and stages of CKD are itching, weakness, tiredness, poor concentration, restless legs, leg cramps, shortness of breath, poor sleeping, and feeling cold.
Lovely. So Our Lady is on bumetanide, which is a leak diuretic for edema. The common side effects include exacerbation of diabetes, electrolyte imbalance, dizziness, headaches, nausea, fatigue, metabolic alkalosis, and muscle spasms. She's on 1 milligram and takes this in the morning. So the loop diuretic is used in the management and treatment of overload of fluid. So for edema, as I said. However, we did spot that NICE guidance recommends a starting dose of 500 micrograms in elderly patients, and this is because they're more susceptible to side effects. And also, it should be adjusted according to a patient's renal function. And Our Lady has CKD, which is one of the contraindications. So we would have a conversation about reducing that dose and also monitor the electrolytes periodically for this lady, and adjust the dose according to the results. She's also got a leg ulcer, which we previously mentioned. And on her prescription, we noticed that she's on an iodine dressing. And this is an antimicrobial dressing used to prevent infections in wounds. So the problem with this is, like bumetanide, it's quite harmful to patients with renal impairment. And this is because the kidneys remove waste products. And if they're damaged, this function is reduced, and therefore it can lead to toxicity. For the dressing, we would discuss with the prescribing clinician and suggest an alternative dressing, which might be more appropriate.
So I'm going to talk a little bit about IV fluids. It's common for patients who've got some sort of renal condition that requires a diuretic for them not to drink because they don't want to go to the loo too often and they don't take their diuretics. So they end up with lots of fluid on board, but they can end up dehydrated as well. because the fluid's not in the right places. It's quite common for doctors and nurses to be cautious about the use of IV fluids when treating patients with renal failure due to the risk of fluid overload or further damage to the kidneys. Although I've read quite a few articles and the jury is still out on the subject of fluid use with kidney damage. Whilst the risk of overload should be considered, restricting the use of fluids in a patient with low circulating volume can be detrimental to their recovery time and prolong episodes of ill health. What has been proved is that patients with pre-existing medical conditions such as dehydration, cardiovascular disease, CKD, they're more likely to be at an increased risk of kidney damage with IV fluids are administered, especially in large quantities. There's two types of solution that are used. Crystalloids, which is in its most common form, is known as normal saline or sodium chloride 0.9%. In addition, crystalloids can also be compound solutions containing sodium lactate. We know them as Hartmann's or Plasma-Lyte. Or they can contain glucose. When normal saline is used in large quantities, hypocaloremic acidosis can occur due to large amounts of sodium being infused into the body, and this can lead to further renal dysfunction, which results in impaired GFR. To reduce this risk, Hartmann's or Plasma-Lyte can be administered instead, as they are more balanced. Crystalloid solutions are isotonic plasma volume expanders, meaning that they increase the circulating volume in the body without altering the chemical balance in the vessels, as they closely mimic the electrolyte composition of the blood. They are used to replace fluid loss due to hemorrhage, dehydration, or loss of fluid during surgery. Colloids are gelatinous solutions that help to maintain higher osmotic pressure in the blood vessels. This is because the molecules are larger than those in crystalloids and cannot pass through semi-permeable membranes such as the capillary membranes, and therefore stay in the intravascular spaces. Due to the fact that the solution remains in the intravascular spaces, certain forms of colloids should be used with caution, as they can temporarily affect clotting times and platelet count. Potential side effects of colloids can also include hypertension, tachycardia, cardiac failure, and peripheral and pulmonary edema. Some colloids contain gelatin, which could pose an ethical dilemma when it comes to vegetarians and vegans, and can pose a risk of anaphylaxis as well, so they should be used with caution. They're also more expensive than crystalloids, but are longer acting, so there could be an argument for their use in terms of needing to use less compared to crystalloids. Although IV fluids are grouped in two categories, colloids and crystalloids, one study concluded that this is too limiting and that each fluid should be considered on their own merits, especially when it comes to being balanced or unbalanced.
Now I'm going to ask if you can do a quiz in your group, so I've got a quiz to hand out. So
Anya loves a quiz. We know Anya loves a quiz.
Thank you. 18.
What's the price?
We need to do it.
Was that the best one?
Above the checklist. Why was the patient pending regular questions? Where is it vector?
I like it.
Final two, but you can. Where does the operation? And there's
I think we don't belong relevant.
Why is What do you think about? I don't just think about. Like that is. Yeah, but
She was on a load of rehab and she was
What's it good for? One good for education.
Is it right?